Welcome back to Decode Healthcare with Harshal for part 47 of our massive 100-part series on the ICD-10-CM official guidelines. Now, if you were hanging out with me in part 46, you know we completely conquered the complexities of CAD and angina combination rules. Today, we have a brand new mission. We're locking our sights on section IC9E, and we are going to absolutely master the acute myocardial infarction, or AMI, coding laws. Using the CMS guidelines as our ultimate, indisputable rulebook, we're going to break down the 28-day acute window, avoid the traps of STEMI evolution, and figure out exactly how to sequence subsequent MIs. Our roadmap for this explainer is super structured to prime your brains for the rules ahead. We'll start with the AMI evolution laws, move into the 28-day acute window, tackle the tricky logic of coding subsequent MIs, and finish strong with type 2 demand ischemia. Let's get right into it. Okay, let's dive into this first section and look at the clinical progression rules right at the moment a patient is admitted. Before we look at how these conditions morph on a patient's chart, we need a quick refresher on the clinical difference. A STEMI, found in category I21.0 through I21.3, is an ST elevation myocardial infarction. This is the big one. It represents a severe total blockage of a coronary artery. On the flip side, an NSTEMI, which is code I21.4, is a non-ST elevation myocardial infarction, representing a partial occlusion. But here's the thing. Patients aren't static, right? Their conditions change. So what happens if an NSTEMI evolves into a full-blown STEMI during the encounter? Well, you code the STEMI. But conversely, what happens when successful thrombolytic therapy, like those life-saving clotbuster IVs, turns a STEMI into an NSTEMI on paper? Guess what? You still code the STEMI. This is the absolute trump card rule in medical coding. STEMI always wins. Think of it like a heavy-duty padlock that permanently locks that code onto the claim form. Once a STEMI, always a STEMI for that encounter, no matter how much the EKG visually improves from treatment. And this brilliantly illustrates how the CMS guideline wording is the absolute law of the land. This specific phrasing overrides any visual changes the physician might see on the monitor. If the documentation states it was a STEMI that converted because of thrombolytics, your coding path is locked in stone. You're coding a STEMI. Moving right along, let's transition into the patient's recovery phase and establish exactly how long an MI is technically considered acute. 28. I want you to literally burn this massive number into your memory right now. In the ICD-10-CM universe, the word acute for a myocardial infarction means exactly 28 days or less. Not 30 days, not a generic 1-month time frame. It is an exact 4-week, 28-day window. Let's walk through a concrete patient timeline so you can see exactly how this works in practice. Day 1, the patient suffers the initial MI. We use the active I21 category code, of course. Now, jump to day 14. They are transferred to rehab. The clock is still ticking, but we are still safely inside that 28-day acute window, so we keep using that active I21 code for the rehab transfer. But then, day 29 hits. The acute window slams shut. For follow-up on day 29 or later, if that MI is healed, you absolutely must switch your code to I25.2, old myocardial infarction. So let's break down the nuances of what happens on and after day 29, because honestly, this is a very common trap. Encounters up to 4 weeks, you use category I21 even for transfers to other acute settings. Easy enough. But what if it's after 4 weeks and the patient is still receiving active care related to that MI? In that specific scenario, you do not use I21, and you don't use the old MI code either. You use the appropriate aftercare code. You only pull out I25.2 for an old, completely healed myocardial infarction that requires absolutely no further active care. Let's move on and see how this builds when we run into a major complication, a second heart attack. What if lightning strikes twice within that initial 28-day acute window? It happens, and when a patient who just suffered an AMI has a new subsequent acute MI within that exact same 4-week time frame, the coding dynamics completely shift. Enter category I22. Here is the golden rule you cannot break. Category I22 must be assigned in conjunction with the category I21 code. An I22 code is not a lone wolf. It cannot stand by itself on a claim form. It's a mandatory 2-code pairing. You need one code to tell the story of the initial heart attack, and the second code to tell the story of the subsequent heart attack. But which one goes in the first slot? let's walk through this simple logic path so you never get your sequencing flipped. Step 1 is always determining the primary reason for admission. Step 2, if the patient is admitted specifically for the second MI, meaning they were already discharged and then had another heart attack at home, you sequence I-22 first, followed by the initial I-21 code. However, step 3, if they were admitted for the initial MI and that terrifying second MI happens during that very same hospital stay, you sequence the initial I-21 first, followed by the subsequent I-22. It is 100% dependent on the specific circumstances of the encounter. All right, let's pivot for a moment to alternative causes of an MI that totally break the standard coronary occlusion mold. We need to clearly define what a type 2 MI, also known as demand ischemia, actually is, so you understand why the logic here is completely different. Unlike a standard type 1 STEMI or NSTEMI, which is caused by a physical blockage in the artery itself, a type 2 MI is secondary to an ischemic imbalance. Simply put, the heart muscle is crying out for more oxygen than the body can provide. This isn't usually a clot. It's often due to a severe underlying systemic issue, like profound hypotension, where the blood pressure is too low to push oxygen into the tissue, or severe anemia, where there just aren't enough red blood cells to carry the oxygen. Because a type 2 MI is a systemic reaction, we have to flip the script. The absolute golden rule here is that the underlying cause must take the #1 spot on the claim. Whether it's the severe anemia, the hypotension, or whatever else is driving that oxygen demand imbalance, that systemic condition gets sequenced first, followed by code I21.A1 for the type 2 MI. When you map these scenarios out side by side, it perfectly illustrates a total reversal in our standard sequencing hierarchy. If a patient comes in for a standard type 1 MI, category I21 comfortably takes slot #1. But for a type 2 MI, the underlying cause, let's say the code for anemia, storms in and steals slot #1, pushing the I21.A1 code down to slot #2. It's a complete role reversal, and trust me, that is exactly why it gets tested so frequently. And just like that, we have conquered section IC9E. We've mastered the 28-day window, navigated the STEMI evolution traps, and locked down the strict sequencing rules for subsequent and type 2 MIs. Before we go, I want you to think about this. If a single day, literally day 28 versus day 29, can completely alter how a multi-thousand-dollar claim is coded, just how bulletproof is your patient timeline? Always double-check those dates. Please remember to subscribe, hit that like button, and share this video with your fellow coders. Next up in Part 48, we are taking on Section IC9D, Cerebrovascular Accidents, Sequelae, and TIAs. It's going to be a great one. Until then, keep decoding.